Most of you guys know me, but my name is Daniel Watford. I'm one of the transplant nephrologists here at University of Washington, and today I'm going to be talking to you guys about BK Polyoma virus nephropathy, current approaches, and future directions. I have no financial or commercial interest to disclose this morning. And some things I hope to cover in this talk is I'd like to discuss BK Polyoma virus nephropathy, background and prevalence in transplantation. I want to provide an overview of the current screening and diagnostic approaches in BK nephropathy, discuss our current treatment approaches, and finish with some highlights of future directions. So first, I'm going to start us off with a case. So this is a 40-year-old female, history of lupus complicated by class 4 lupus nephritis, previously managed with corticosteroids, mycophenolate, and hydroxychloroquine. This patient ultimately progressed to ESRD and subsequently underwent a living unrelated kidney transplant. She received induction with thymoglobulin, and it was maintained on tacrolimus, myfortic, and prednisone, in addition to continuing her hydroxychloroquine. Post-transplant course was uneventful, and she achieves a stable and excellent allograft function with a creatinine of 1 to 1.1. Approximately 14 months post-transplant, she had been experiencing a sort of a gradual rise in her creatinine over the last 3 to 4 months. Creatinine initially, as I mentioned, about 1.1, had risen up to 1.6. She denied any urinary symptoms, any graft tenderness, fevers, chills, or any signs or symptoms of lupus. Her exam was essentially unremarkable. She was normotensive, had no edema. As I mentioned, no pain over her transplant. Just going to pull out some of the prevalent, most prominent labs. So her tacrolimus trough at this visit was 7.5. Checked to see if she had any antibodies. They were negative. The urine was bland with just mild proteinuria, UPCR of 0.3 grams per gram. Subsequently, we checked the BK urine PCR on her, and it was quite elevated, 850 million copies per mil. So this prompted us to subsequently check a serum BK PCR, and that also was elevated at 250,000 copies per mil. So proceeded to perform a biopsy on this patient. And I do want to talk about, obviously, the point of this talk is we're talking about BK nephropathy today, so no secret there in terms of diagnosis. And I will talk a little bit about typical biopsy findings in these patients. But before we do that, I want to talk a little bit about BK and some background. So BK polyoma virus is a DNA virus that was first isolated in 1971 by Sylvia Gardner, who was a virologist at the Virus Reference Laboratory in London. It was cultured from the urine of a 39-year-old Sudanese male kidney transplant recipient who later ultimately developed complications, including urethral stenosis. We don't actually know his full name, as it was not released in the medical literature for patient privacy purposes, but his initials were BK, and that prompted the name that was given to this human polyoma virus. And this marked the identification of this virus that was later determined to cause problems for immunocompromised patients, particularly those with kidney transplants. So the vast majority of our population has experienced asymptomatic exposure to BK virus, usually in childhood, with adult seropositivity levels approaching approximately 90%. Resides latent in the kidneys, specifically in the renal tubular epithelial cells and in the uroepithelium along the urinary tract. Generally remains quiescent unless antiviral immunity is reduced, typically with chronic immunosuppression, allowing for viral reactivation. And then I just want to mention that it can lead to a few other complications, notably, as I mentioned in the patient that it was first cultured from, developed urethral stenosis. But you can also find things like hemorrhagic cystitis and ultimately graft injury and failure. BK can infect the lining of the ureters, which leads ultimately to inflammation and subsequent narrowing and scarring, and therefore leads to a stricture or a stenosis. This is a more advanced presentation of BK nephropathy, but certainly something we can see. And then I mentioned this, it also can lead to hemorrhagic cystitis. This is something that we most commonly see in our hematopoietic stem cell transplant recipients. Whereas it can cause severe inflammation, just like in the ureters, but also in the bladder, leading to bloody urine or hematuria, pain, urgency, frequency, and in really severe cases, patients can even develop blood clots and ultimately have obstruction related to those blood clots. So I wanted to show this graphic here, and this just gives us a sense. So I want to highlight that in order to control BK virus and make sure that the virus stays latent without reactivation, you're relying on BK-specific cytotoxic T cells. And when these cells achieve viral clearance at an early stage, intragraft inflammation remains low, and therefore you don't have progression of BK polyomavirus nephropathy. However, when the cytotoxic T cell response is not able to achieve viral clearance, you can develop chronic BK replication, which causes massive intragraft inflammation, and subsequently can lead to chronic allograft damage related to the BK virus. Sorry about that. I also want to show this figure. This is a figure taken from a 2016 review in transplantation that illustrates the pathophysiology of BK polyoma virus nephropathy. And so what it shows here is, starting up here, you have your normal kidney, and it depicts development of latency in the uroepithelium at the top, all the way down to developing renal inflammation from further replication of the virus. And this subsequently can lead to cellular necrosis, viuria initially, an infection of the adjacent cells. The basal membrane can be damaged, and you can subsequently develop viremia as it makes its way into the capillaries and into the bloodstream. And this leads to nonspecific inflammation and ultimately nephropathy. And as this progresses over time, this can lead to chronic injury and fibrosis in the kidney. So it can be quite a problematic issue if we're not able to control the virus. So, all right. BK is a relatively common complication in kidney transplantation, with studies estimating as high as 10 to 30% of patients developing BK viremia and up to 10% developing nephropathy. I wanted to point to, I took this graphic here from a study. This was a Canadian prospective study where they followed kidney transplant recipients who underwent indication biopsies anywhere from 6 days to 32 years out from transplant. And so out of 315 recipients, 60 of them progressed to kidney failure with a median follow-up of 31 months. And cause was assigned by the researchers based on the biopsy findings and also the clinical history in these patients. And then I just want to highlight one thing here. And so in their study, they found that BK nephropathy accounted for as much as 7 to 8% of all kidney allograft failures that they encountered in that study. So not a small matter. Certainly not the largest cause of graft loss. Antibody-mediated rejection is still the largest cause, but certainly something that we need to pay attention to. All right. Sorry, also taken from this same study, I want to point to, they also performed these conditional probability plots that show the probability of each diagnosis and how that changed over time post-transplant. And so I just, there are lots of causes here, but I want to highlight here, this green dotted line here is the BK polyoma virus nephropathy. And where they found it to be the most common timing of the developing BK virus nephropathy was between 6 months to 1 year out from transplant. So it's important to keep that in mind when you're following these patients and evaluating them through their transplant course. And this makes sense. I think this is generally the time where immunosuppression is usually at its highest. And so as we talked about, BK is a replication of BK virus is a sign of generally of over-immunosuppression. And so, which may be why we see it more commonly early on post-transplant. All right, and then this here, I want to talk a little about the cumulative incidence of BK nephropathy. So this graphic here I took from a cohort study. It was done in Australia, and it used the Australian and New Zealand dialysis and transplant registry data. Includes over 14,600 kidney transplant recipients in Australia and New Zealand who were transplanted between 2005 and 2019. The median follow-up time in this study was 65 months, and they've noted that the cumulative incidence of BK nephropathy at the 1-year mark, as we see here, was about 2.5%. At the 2-year mark, they found that it was about 2.9%. And then going all the way out to 3 years, the cumulative incidence was up to 3.3%, respectively. And then I want to point here, the median time to diagnosis post-transplant was about 4.8 months, with the majority of cases occurring within the first year, as I mentioned. All right. And then also looking at causes of graft loss separated out by patients who were found to have BK nephropathy versus those who did not have BK nephropathy in red. I want to point you here, as much as 30% of patients who actually were found to have BK nephropathy actually lost their allograft due to BK nephropathy, as opposed to other causes here. Okay. So moving on, I want to talk a little about some risk factors for BK nephropathy. And so this graphic is taken from a 2018 systematic review and meta-analysis of looking at risk factors for BK viremia and nephropathy based on prospective observation studies. They looked at 34 different publications that were included for their qualitative analysis. And they essentially performed multivariate regression analysis to calculate odds and hazard ratios for developing BK viremia and also nephropathy. And the smaller arrows are lower odds of developing BK nephropathy versus the larger areas being kind of more large risk factors there. So big ones are presence of a urethral stent, which we use routinely here at University of Washington, and many transplant centers do as well post-transplant. Another risk factor is receiving a deceased donor transplant. Having a prior transplant is also a risk factor, likely a representation of cumulative immunosuppression over time. Having episodes of acute rejection, male gender, also advanced age for the recipient, tacrolimus-based regimen as opposed to cyclosporin-based regimen, and then also delayed graft function are other big risk factors. And then I want to highlight one of the things. So these are all risk factors for BK viremia. And then kind of the biggest risk factors for actually developing BK nephropathy noted on biopsy are having a tacrolimus-based immunosuppression regimen and also episodes of acute rejection. So I talked about a few of these, just kind of going over a few other risk factors. So older age, male recipients, use of tacrolimus compared to cyclosporin we talked about. Also it's worth mentioning, higher steroid doses do increase your risk of developing BK nephropathy. And then another thing that we should highlight is that BK polyoma virus seronegative recipient status, receiving a donor who's seropositive, is a big risk factor for developing BK nephropathy, and also low-level recipient neutralizing antibodies against donor BK serotype preceding transplant. I bring these up, but it's also worth mentioning that these aren't commercially available assays for us to screen, and we do not routinely screen that in our transplant recipients, but maybe an area for future direction as we look for ways to best prevent development and control BK nephropathy in our transplant patients. And I can talk a little bit about that kind of towards the end when we get back into future directions. So going back to our renal biopsy, and I know we have our pathologist here on the line as well today, so please feel free to chime in or add anything additional as you see fit. And but I just wanted to highlight a few kind of major things that you'll see on a biopsy when you're diagnosing BK nephropathy. So a big thing is you'll see enlarged tubular epithelial cell nuclei with intranuclear viral inclusions, and we call this the cytopathic effect of BK virus. You also see margination of chromatin in the nuclei of infected tubular epithelial cells, and it kind of gives the nucleus this sort of smudgy appearance. These, as I mentioned, BK typically affects the tubules, and so you can see tubulitis, but generally this is focal and patchy. You can also see tubular inflammation, predominantly in a focal patchy pattern. And this is relative to, say, like acute cellular rejection, which can sometimes be confused with BK nephropathy. And I'll talk about some other high-level findings in BK to sort of differentiate those. But generally, when you're dealing with acute cellular rejection, there's more diffuse interstitial inflammation and also diffuse inflammation in the tubules, including those tubules who do not demonstrate the cytopathic effect that we mentioned. And then as BK nephropathy goes uncontrolled, you can develop interstitial fibrosis and tubular atrophy and subsequently more chronic damage. And that's when you're getting into concern of losing that allograft. And I think it's important to recognize that there can certainly be sampling error that can make diagnosis sometimes more difficult because of the focal and patchy nature of the BK infection in the kidneys. It's recommended that you sample, and this is the case for most of our biopsies anyway, but recommend that you sample at least 2 or more cores to improve the yield and avoid sampling error. And a big thing that's really helpful when diagnosing BK nephropathy is our immunohistochemical staining. And so you can stain for simian virus 40 T antigen. And so this, you'll hear our pathologist mention SV40 positive. And this is generally seen in the infected tubular cells and sometimes the glomerular epithelial cells. And this is diagnostic for polyoma virus. And this applies both for BK virus and also JC virus, which is another polyoma virus as well. And then I just wanted to show you here, this is an example of positive SV40 stain. So as you can see here, the nuclei are staining positive here on them. And so quite obvious that this would be positive and concerning for BK nephropathy. All right. So how's it classified? Well, initially, there was initial Banff classification that was given to different stages of BK nephropathy. And this was essentially based on the degree of fibrosis that was present. And so first it was stage A. And this is sort of denoted as minimal damage. You do see these cytopathic viral changes, but with minimal fibrosis. Stage B is more moderate damage, still again with the cytopathic viral changes we talked about, but with more advanced IFTA and inflammation present. And then stage C is more extensive fibrosis with tubular atrophy. At that point, you're talking about more advanced damage or more chronic injury there. Since that initial Banff classification, they modified these. And so the current Banff classification that we use is broken up by class 1, class 2, and class 3. And this classification, as opposed to the one I showed you previously, this takes into account the percentage of tubular cells that demonstrate viral replication. And so in class 1, you're looking at less than 1% of tubules with viral replication present, and no or very mild fibrosis is present at this point. Class 2, you can have minor, moderate, or more extensive tubular cell infection. And by more extensive, they mean greater than 10%. So if you have minor tubular cell infection, this, along with moderate to severe fibrosis, would fall into class 2. If you have moderate tubular cell infection with any extent of fibrosis, that also would qualify as class 2. And then subsequently, if you have greater than 10% of tubular cell infection, but with minor fibrosis present, that also would qualify as class 2. And then for class 3, you're talking about anything with greater than 10% of tubular cell replication, and as well associated with moderate and severe fibrosis, so the most advanced class. And that's how we generally stage BK nephropathy now. All right. So screening. Now, screening is extremely important, and essentially screening is the cornerstone of initial management in BK nephropathy. Based on the current international guidelines, recommendation is to screen kidney transplant recipients for plasma PK polyomavirus loads monthly until the first 9 months post-transplant, followed by every 3 months until about 2 years in just a solitary kidney transplant recipient. And if we're talking about simultaneous kidney pancreas transplant recipients or pediatric transplant recipients, you want to extend that screening out to 3 years. There have been studies that have shown this is cost effective. The cost of screening is offset by reduction in immunosuppression costs and also certainly complications related to late diagnosis of BK nephropathy and ultimately complications of the allograft. What's our approach at University of Washington? Well, actually, at University of Washington, we generally start with screening of BK PCR in the urine. Because as I showed earlier, when you first have viral reactivation, this first manifests in the urine. So this may provide a bit of an earlier signal. And then if levels are high enough, we would proceed with screening in the blood. And depending on what those findings show, or if there's allograft dysfunction, you may proceed to a biopsy. So our current approach is we'll screen monthly for the first 3 months, and then at 6 months, 9 months, 12 months, 18 months, and 24 months, and then yearly thereafter. And, there may be some slight variations between our providers, but generally, we become concerned about viremia when the levels in the urine are greater than 100,000 copies per mil, or also rapidly increasing, which may prompt us to check in the plasma. All right, so moving along, and sorry, I can't, please let me know if anything pops up in the chat, but so management, first off, I want to make the point that there are currently no approved antiviral treatments for BK viremia or nephropathy. Okay. And so reduction of immunosuppression is the crux of treatment when we're talking about managing BK viremia, BK nephropathy. Now, there are different approaches to this, but the main approaches are, of course, reducing immunosuppression. Most transplant centers, use triple immunosuppression in our transplant patients, but generally these are tacrolimus-based regimens with mycophenolate. And so the main different approaches are you can either first reduce the calcineurin inhibitor target trough level by 25 to 50%, followed by reduction of the anti-metabolite, in this case being mycophenolate, by up to 50%. And then if still not seeing improvement in the viral levels, this may be followed by cessation of the anti-metabolite, versus the alternative being reducing the anti-metabolite initially by 50%, followed by reduction of the calcineurin inhibitor target trough by a similar level of 25 to 50%, and then ultimately followed by cessation of the anti-metabolite. There's evidence behind both, but I will say that most U.S. transplant centers at this point generally start with reduction of the anti-proliferative or anti-metabolite agent. And the idea behind this is that, mycophenolate has an effect on both B and T cells, whereas the calcineurin inhibitor generally affects T cells directly. And so by reducing immunosuppression from both entities, B and T cell, you may elicit an immunologic response to the graft and allow you to clear the infection or the viral levels sooner. And that's typically our approach by our providers here at University of Washington, myself included. I think it's also important to note, though, this is not without risk. So, sorry. So I want to highlight, this is a single center retrospective matched case control study that was done at Northwestern. And this looked at over 1,900 kidney transplants that were done between 2007 and 2017. There were 190 included BK cases compared to 396 matched controls. And then I want to point out that, sorry, my mouse is giving me, there we go. I want to point out that first off, the rate of development of de novo donor-specific antibodies was significantly higher in the BK case group compared with the controls. As you see here, 22% in the BK positive patients versus a little under 14% in those who are BK negative. And we also noted that the time to development of de novo DSAs was much earlier in the BK positive patients at 294 days versus 434 days. And what this does is this suggests a need to carefully monitor for development of DSAs in this group and concern for rejection. So, just not reducing immunosuppression without monitoring and watching these patients very closely. Okay. All right. So all right, I'm trying to move here quickly. So I want to talk a little bit about some alternative agents that are used beyond just reducing immunosuppression. And I want to highlight that this is, again, reducing immunosuppression is going to be the most important thing. But if you're not seeing improvement, these are kind of the main agents that are considered today. Fluoroquinolones, which is much less now than previously. Leflunomide, we still use quite a bit, and we also use it here at University of Washington, and also IVIG. Uh, Formulations. So first off, I'm going to move here quickly, but there is in vitro data that suggests that fluoroquinolones can inhibit the helicase activity of the SV40 T antigen protein, which is important for regulation of viral replication. And then there have been other studies that have suggested that fluoroquinolones are effective against several DNA and RNA viruses. So in this one study I want to highlight here in the top, they tested four different fluoroquinolones. This was an in vitro study, looking for the ability to limit SV40 viral DNA replication. And they did show that at both 72 hours and 96 hours post-exposure, the viral replication was reduced from all the different agents. For whatever reason, they note the concentrations here a bit differently, but even in levofloxacin as well. And then there was also a single center retrospective study that was done out of the Brigham that found higher rates of BK viremia at 1 year in groups of patients who did not receive a month of fluoroquinolone as part of their initial prophylaxis post-transplant. And so much higher rates of BK viremia in that group compared to those who did not. So a signal. However, I want to point you, and this is one of the best studies that was done. This is a multi-center, double-blind, randomized control study that was published in CJASN in 2014, also by a group out of Harvard that enrolled transplant recipients with BK viremia and randomized them to 30 days of receiving levofloxacin, 500 milligrams daily or renally dosed, depending on what their kidney function was, versus placebo. And then at 3 months, the levofloxacin and placebo groups had similar reductions in BK viral load at 70.3% versus 69.1% respectively. And the number of study participants with a greater than 50% reduction after 3 months was also essentially equivalent. And then what this study essentially showed was it demonstrated that there was really no statistically significant difference in BK viral load between those groups at 1 month, at 1 month, 2 months, 3 months, and 6 months. And so essentially a 30-day course of levofloxacin did not improve BK viral load reduction or allograft function when used in addition to overall reduction of immunosuppression. So a randomized control trial showed that, probably levofloxacin does not have great evidence behind treatment of BK viremia and BK nephropathy. So moving along, I want to talk about leflunomide. And so for those of you who don't know, leflunomide is an immunosuppressive agent that's originally approved in rheumatoid arthritis, but also has some antiviral effects, which makes it an attractive option when we're trying to manage BK viremia in our transplant recipients. For the sake of time, I won't get into the mechanism too much, but essentially it blocks lymphocytic proliferation by inhibiting an enzyme required for de novo pyrimidine synthesis, and also alters intracellular signaling of T and B lymphocytes. And so there was so showing here, this is a prospective observational study from the Cleveland Clinic screening over 600 kidney or pancreas transplant recipients from 2007 to 2011 for BK viremia. And then sorry about that. There were 130 recipients who had BK viremia detected during the first year post-transplant. And in this study, they separated them into 5 categories according to the treatment that they received. The treatments were chosen at the discretion of the treating physician and reflected disease intensity based on viral loads and clinical symptoms. So the more aggressive therapy were generally reserved for those who had higher viral loads initially. And so the different arms are just observation alone, decreasing or stopping a certain immunosuppression. decreasing or stopping immunosuppression plus adding on ciprofloxacin, decreasing or stopping immunosuppression plus adding on leflunomide, and then ultimately just decreasing or stopping immunosuppression plus adding on leflunomide and ciprofloxacin. And what they did is they compared the rate or the slope of BK viral load decline among the 5 groups. And while those with higher peak BK viral loads were more represented in groups 2 and 5, there was no statistically significant difference in the slopes, essentially describing similar rates of viral clearance for each treatment group. So based on this, the authors conclude that there's no benefit to addition of ciprofloxacin or leflunomide for viral clearance of BK, and also noted significant side effects and toxicities, particularly hepatotoxicity and bone marrow suppression being the most common. The leflunomide, it's worth mentioning that the leflunomide dosage used and the target levels used in some of these studies was inferred from its in vitro inhibitory concentration, 50% inhibitory concentration against viral replication, which historically has led to higher treatment dosing. However, a study that was done by many of us here many of you guys in the audience, including Dr. Lecca, Dr. Musinski, Dr. Jefferson, and Dr. Pitchler, and Dr. DeBoer demonstrated that there is excess morbidity without improvement in viral clearance rates from targeting higher therapeutic leflunomide levels, and even some more unsavory side effects, including one case of TMA. But I do want to highlight a systematic review that was done that summarized approximately 20 clinical studies that included leflunomide as a management strategy for clearance of BK viral levels. And though the overall evidence quality is low and a lot of heterogeneity with no randomized large control trials, there was a signal that that leflunomide may have an effect in helping reduce viral loads compared to just reducing immunosuppression alone. And so we do still, quite a few of us do still use leflunomide, particularly if we're not seeing improvement in the viral levels with reducing immunosuppression. And generally what we target is a drug level of approximately 20 to 30 nanograms per mil, as opposed to the traditional 40s to 60, which was done in the past and leading to more side effects. All right. Lastly, I'm going to talk about IVIG. And so what I'll say here, there was a study done out of Pittsburgh that essentially found that all commercially available IVIG preparations do contain anti-BK polyoma virus neutralizing antibodies to all major genotypes of BK. And so it makes sense that, this might be an agent that could work well for treating and managing our patients with BK viremia. And so the most recent international guidelines do suggest IVIG can be used as an adjuvant therapy to facilitate viral clearance in those kidney transplant recipients who have insufficient response to immunosuppression reduction, and as a means to prevent acute rejection and development of DSA in those recipients with higher risk during immunosuppression reduction. There was a recent systematic review looking at studies that evaluate IVIG therapy in kidney transplant recipients with both viremia or nephropathy. And though the included studies were mostly observational and there were no randomized control trials or large cohort control studies, the authors did conclude that IVIG combined with immunosuppression reduction may be beneficial as an adjunctive treatment for reducing and clearing BK viremia. Still unclear the impact on overall long-term graft function and survival. But again, a signal that this is a worthwhile agent to utilize if we're not just getting the effect we want from the immunosuppression reduction, and a large part why the current guidelines still include the use of this agent. All right, I'm running over time here, but I just want to quickly talk about some potential future directions. And so, as I mentioned, presence of BK viremia and nephropathy is generally a sign of too much immunosuppression in the body's inability to clear the virus. And so one area that's taking hold, certainly in transplant in general, is use of monitoring of torque-tenovirus, which this is a circular non-enveloped DNA virus that infects essentially all humans. But fortunately, it's not pathogenic, but it does replicate in response to the net level of host immunosuppression. So essentially, if you're seeing higher levels of torque-tenovirus, this means that you're probably over immunosuppressing the patient versus if you're seeing very low levels, you may not have enough immunosuppression on board and maybe even be at risk for rejection, but also you can use this to assign risk for developing BK viremia, knowing that too much immunosuppression is going to lead to likely development of BK viremia and ultimately BK nephropathy. This is an emerging biomarker that, again, as I mentioned, serves as a surrogate marker of the overall net state of immunosuppression after transplant, and I think could be a useful tool in predicting the risk of BK nephropathy, and subsequently could allow us to make more proactive adjustments to immunosuppression regimens even prior to seeing development of frank viremia. So I would say it's not used regularly in transplant patients for this purpose. I mentioned before assessment of recipient neutralizing antibodies against donor BK serotypes preceding transplantation. If we had commercial assays available to test this, it might provide a better understanding of BK immunity and allow for more targeted screening strategies in patients who are at higher risk. But we unfortunately lack those commercial assays, including assays to assess for cellular immunity for BK in ways that we have for other pathogens such as tuberculosis with our interferon gamma release assays like quantiferon gold and also cytomegalovirus. But there's a test called a quantiferon CMV, which are both interferon gamma release assays. It would be really nice if we had something similar for BK virus. So, but maybe on the horizon. I want to mention one other thing, anti-BK polyomavirus monoclonal antibodies. So beyond polyclonal IVIG products, which are traditionally used, there's an investigational product known as MAU 868 from Vera Therapeutics, which essentially is a human monoclonal antibody that binds the viral capsid protein VP1 of BK virus and has demonstrated broad neutralizing activity against clinically relevant BK variants in vitro. It was tried in phase 2 randomized clinical trials that have not been published yet, but an abstract from a recent ATC did demonstrate that 75% of subjects who received the drug experienced a greater than 1 log decrease in viral load at 36 weeks, compared to a 50% reduction in placebo group. And their phase 2/3 randomized control trial is ongoing, and that's the national clinical trial number there. For the sake of time, I'm going to try to move quickly here, but another thing that is being investigated is brincidofovir, which is an IV prodrug of cidofovir. Cidofovir has fallen out of favor, and it initially was considered as a therapeutic agent for BK, but found to have very minimal benefit with a lot of risk, including injury to the kidney, and so that's not used any longer. But brincidofovir is available for use against smallpox and monkeypox, and has shown some in vitro activity against BK polyoma virus. And there is a planned phase 2 open-label randomized controlled trial called Bastion, and there was to evaluate the safety and tolerability of brincidofovir in patients specifically with BK viremia after kidney transplant. Unfortunately, this study was halted due to an inability to achieve target enrollment, and so no news of that plan to restart that study, but would have been a promising option as well, and we'll see if they'll revisit that. So some conclusions. Big points I want you to take is that screening remains essential to the management of BK viremia and nephropathy. Again, there are no approved antiviral treatments for BK polyoma virus. Reduction of immunosuppression remains the cornerstone of treatment, with most centers starting with reduction of the anti-metabolite agent first, followed by the CNI. It is reasonable to trial some alternative agents, particularly leflunomide and IVIG in more refractory cases, but only after reduction in immunosuppression. And note that high-level evidence is lacking and dosing is not standardized in these cases either. And it's critical to monitor closely for side effects associated with several of these agents, particularly as I mentioned with the leflunomide. The big ones you are concerned about generally are hepatotoxicity and bone marrow suppression. There are several areas for future work, including a need for development of better directly acting antivirals, such as antibody and cellular therapies, and also need development of ways to assess which patients are at highest risk for developing BK viremia and ultimately nephropathy. So still a ways to go. And then here are my references here. And with that, thank you. And sorry, I ran quite a bit over there in terms of time.